Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. I am one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. I am so excited to help bring you the latest and greatest in thoracic surgery. I could not be more excited to be joined today by two absolute tour de force surgeons in the world of thoracic oncology, my co-host extraordinaire, Dr. Jane Yanagawa, and of course, a favorite of Thinking Thoracic, Dr. Leah Backhus. Leah and Jane, welcome, and thank you so much for being here with me today.
Thank you, Erin. Nice to see you. Good to be here.
You guys, we are here to talk about such an exciting topic in honor of May, which is Women's Health Month. And for our amazing listeners, every single May, beginning on Mother's Day, the Department of Health and Human Services and the Office on Women's Health leads a National Women's Health Week that focuses on preventive health services. And it kicks off now an entire month. So to all the women out there and to all of our mothers, happy Mother's Day and a happy Women's Health Month. All right, you guys. So let's jump in. We really are so excited to be talking a lot about women and how they're impacted by lung cancer today. So to really help us set the stage, Leah, talk us through a little bit of the lung cancer statistics for women in the United States and what we are seeing as the impact of this disease.
Thanks, Erin. Again, thanks for the opportunity to chat with you all today. In the U.S., anyway, for 2026 is estimated about 118,000 new lung cancers will be diagnosed this year, which is an expected 61,000, almost 62,000 anticipated deaths from those. And that's really going to be more than cervical, ovarian, or breast cancer combined. That's just talking about women. It's not even talking about the impact on men, but obviously apropos to the subject of the day, a huge number of women affected by this.
And it's sort of a sobering statistic when you think about it and sort of the population at large in a country. It means that almost everybody is going to be touched in some way by lung cancer, whether it is a friend, a sister, an aunt, a grandmother, a mother. So many of us will be impacted by this disease.
Absolutely. It couldn't be more important to discuss.
So one of the scary statistics that really sticks out in my mind a lot is, unlike the drop that we have seen really over the last couple of decades in the incidence of lung cancer in men, that has sort of correlated well with that smoking drop that we saw, we haven't really seen the same thing in women. And in fact, for women between the ages of 35 and 54, we've actually seen an increase. And so we really need to start thinking more creatively about how we're thinking about identifying these cancers. And so with that in mind, I wanted to dive and chat with you guys just a little bit about the NLST, the talent trial, lung cancer screening in general, and how we need to be thinking about this for women. So Jean, tell us a little bit about your thoughts about these trials, about screening, and what we need to be thinking about.
Yeah, I mean, obviously, lung cancer screening has had such a huge impact in general. In terms of diagnosing not only lung cancers, but finding them earlier and catching them earlier so that we can make a bigger impact with our treatments. But I think one of the major limitations is the fact that we don't understand what are all the risk factors for lung cancer, and so if we are not screening the right people, then we could potentially miss a lot of people. And actually, in my own practice, I have found, we look back on our data, and the far majority of patients that I am seeing with early stage 1 lung cancers are women, and also are women who never would have qualified for screening for lung cancer here in the U.S. based on the current guidelines that we have, and that's looking at like multiple different guidelines even. So I think that we definitely need to have a better understanding. Some of the trials that you mentioned, like the Talent trial, the FANS FANSS female Asian never smoking screening study trial that was conducted at NYU. These are all studies that are trying to figure out what are potentially some other risk factors other than smoking, which is like the main criteria of all of our US guidelines. So, for example, in other countries like in Taiwan, which is where they conducted the Talent trial, they screened people who had never smoked before, but might have one other suspected risk factor. So, exposure to other people's smoke, a family history of smoking, a history of smoking in cooking in an enclosed space, things like that, that might affect women more historically than men. And so, the results of those studies show that they captured even more people with lung cancer than the NLST, by looking at a population that doesn't smoke at all. They especially found that, a family history could increase your risk. So I think that there's still so much more to learn about who is at risk for lung cancer to refine our screening practices.
I want to grab onto one really important thing that you said, because there was a beautiful paper that came out of Northwestern, and I think it was last year, 2025, looking at all of the women that they diagnosed with lung cancer and what percentage of them would not have qualified for lung cancer screening. And it was like 65% based on our guidelines in the United States, which was a really sobering statistic to suggest that we really are under screening women.
Right.
And actually, that number is more like 80% if you look at the Asian population, right?
Yeah. Yes.
So it only goes up from there. I would say that 60% is probably a conservative estimate, depending upon where you apply those statistics to. So it really is a major call to action there to try to figure out how to best capture and identify lung cancer earlier in these women, because that's a travesty. A stage 4 lung cancer shouldn't be happening when we have actually screening tools to detect them earlier.
Absolutely. So as a reminder to our listeners, would one of you guys just be willing to mention the key screening criteria that we are currently using in the United States that are sort of approved guidelines through the USPSTF that Medicare and our insurance companies will pay for? Because I think that's really important in the context of this discussion.
Yeah, well, so the first set of guidelines came out in 2013 by USPSTF anyway, on the heels of NLST being published in 2011. And those criteria were age 55 to 74, 30-pack year smoking history, and having quit less than 15 years ago. And then, of course, there was a shared decision-making visit that would be partnered with that screening intervention. And then in 2021, the USPSTF revised their criteria, liberalizing the age and the smoking requirements. So then the age came down to include 50-year-olds, so down to 50 and up to 80, so between 50 and 80 years of age, and reduced the pack years from 30-pack years to 20-pack years. It still maintained this quit less than 15 years ago, however. And then the shared decision-making visit, of course, has been carried through. And now there's this huge, push by many entities, including American Cancer Society and National Comprehensive Cancer Network, to remove the quit less than 15 years ago. Because in doing so, not only are we going to improve lung cancer screening for women in terms of expanding the eligibility criteria, but for a whole lot of other groups who are otherwise being currently underscreened. So it's going to be one of those, rising tide floats all boats kind of thing. It's not just that this is a target intervention specific for women, but women will benefit disproportionately so, which is good, as well as some of these other groups that are also being currently underscreened.
Absolutely. And there's a lot of concerns too surrounding total exposure, right, to the smoke, thinking that perhaps it differentially affects different portions of our population. So perhaps a lower total smoking history would be more appropriate for, women as a cohort, versus men as well, because it might have a differential impact because we're seeing higher rates of cancer and lower amounts of smoking, resulting in a lot of these patients not being eligible for screening, which is discouraging.
Yeah, to remove the pack years and instead
Hmm.
just be number of years of exposure would be one of the ways to kind of circumvent that. I mean, the flip side of all of this, of course, right, is that all of the folks who otherwise are responsible for lung cancer screening from a payer standpoint are disincentivized to have very broad criteria, right? Because for fear of overwhelming the system, being unable to deal with the, sort of barely keeping up with lung cancer screening now and its underutilized state, let alone if we were to be 100% successful at our endeavors, knowing that we probably won't have capacity, nor would we have financial capacity to be able to support that. So, and also, of course, trying to make sure that we don't, bring in any undue harms to patients as well. I definitely think the harms thing is woefully overstated. But of course, those are the arguments against it. But we can argue, I think, effectively to support it.
Absolutely. And even I'm glad that you mentioned about the false positive rate, because that's frequently used as one of the biggest concerns, because we do find a lot of benign findings, right? Tons of people have pulmonary nodules. The vast majority of those will be benign. But I think as we've really seen, lung cancer screening develop, we've seen this beautiful corollary development in robust radiographic criteria for how to classify and follow nodules that are less likely to be malignant. We have tons of AI in development that is also helping to subclassify these. And so I think that the fear of these additional findings is going to continue to get less over time, or at least that's what I'm hopeful, because we see, so many of these every single day and manage them without too much thought now that we have a very experienced program.
I think it's unfair scrutiny as well, right?
Yeah.
Because nobody counts the number of polyps removed for a colonoscopy. Nobody counts the number of negative breast biopsies necessarily anymore, right?
Yeah.
And yet the lung
Yeah.
cancer people, fall under this added scrutiny, which I think is completely unfair. Because if you looked at, the number needed to treat, et cetera, number needed to screen in order to prevent lives lost, et cetera, lung cancer is by far a winner above any of these other cancer screening opportunities. So it
Absolutely.
doesn't fit that it should
Yeah.
be handicapped in the way that it is, despite the overwhelmingly positive benefits.
Yeah, one of the CT chest imaging for CT coronaries, right, is how like a lot of
Yes.
these incidental lung cancers are being discovered.
Yep.
And everyone talks about not screening for your coronary artery disease
Hmm.
because of the incidental findings.
Yeah, absolutely. Absolutely. That it's funny you mentioned that. That's probably our number one most common way that we're finding incidental lung nodules in our incidental lung nodule program is actually the CT coronary studies, which always captures just a small part of the lungs. But it's finding a lot of things, which is great.
Yeah, absolutely. We actually have a couple of studies underway at Stanford looking at that overlap, one of which was just presented at the STS this past meeting, looking at that overlap for the opportunity to capture lung cancer, not or lung nodules anyway, within the context of CT chest being done for all sorts of reasons, but
Yeah.
specifically we looked at cardiac reasons for aortic pathology surveillance, and then of course the coronary calcium scores. And what we found actually was that we didn't look at it broken down by gender, but that would be really interesting to do. We found that the majority of the lung cancers that were identified on those scans were not in again, not in people who otherwise would qualify
Yep.
based off of current guidelines, which is interesting. But I think that this is a novel population that clearly they've got something, but yet their incidence of lung cancer was far and away much higher than the average population.
Yeah.
So this is another at-risk population that we're not really presently paying attention to. And certainly not even capturing all, like you said, if you were dealing with very limited lung fields, you just happen to catch one
Right.
little sliver of a nodule.
Yeah, absolutely. Now, how are you guys managing incidental lung nodules? Do you have incidental lung nodule programs? Are those getting filtered to you guys directly, or PCPs managing them? Just out of curiosity, Jane, what are you guys doing?
We have a lung nodule conference that is run by radiology, actually, where we
Nice.
discuss incidental nodules, screening lung nodules, and then just cases that members of our group want to bring in for discussion. But it's incredibly valuable.
Awesome. I love that. Shifting gears just a tiny little bit, because I think that one of the biggest concerns and worries that I always have is we become very reliant on technology and helping us to provide reminders, right? Of, hey, this patient qualifies for lung cancer screening. And I read a sobering study recently that in some medical record systems that have been evaluated, only 12% of the smoking history is accurate. Now, there's another study that has shown that if we give patients the opportunity to self-report, we're likely to get a more accurate history than somebody asking them, because it's a little less stigmatizing. Have you guys started to solve this problem? How are you tackling the challenges of the medical record? Any hot tips, tricks that we can share with our listeners that is going to allow us to continue to at least capture the people who currently qualify?
Well,
For the smoking ascertainment, we actually in our cancer center instituted it as a quality metric, such that I mean, every cancer center is ran a little bit differently, but in terms of the way that sort of these little additional funds would flow, were predicated on how well we were capturing in every clinic visit across the board in the cancer center one smoking history. I mean, granted, the cancer center is a small sliver of the entire, medical enterprise, but I mean, the fact that if we can't capture smoking, we have no hope of, of actually
Yeah.
getting people screened, right? So that's one way. You attach it to people's monetary incentives, and then all of a sudden, providers get really interested in trying to get a very accurate smoking history. But even with that, we found that there were tons of discrepancies if you
Yeah.
looked at longitudinal smoking data and how it's captured in the medical record, such that you have a you know, a, a prior smoker who's now subsequently listed as a never smoker. Well, logistically, that can't happen, right? And
Yeah.
yet that's what's reflected in the record. And so we've been working with our analytics teams in developing what we call smoking smoothing algorithms to try to adjudicate that and come up with like a ground truth. But I love your idea, and I think it has a ton of validity, Erin, to query the patients directly. I actually had a patient the other day reach out to me because she didn't like the way her smoking history is documented in her
mhm.
clinic note, because she was reading it as years of smoking rather than pack years. And so, like, I had to have a whole message to her
Mm.
about how we actually look at pack years, and like it was accurate. It just, it was off-putting to her
Yeah.
because there is a disconnect in terms of how we look at smoking and how patients themselves look at it and the stigma and all, like,
Yeah.
I
yeah.
mean, I think that's like one of the hard things about lung cancer screening is that we need more information than, for example, like, oh, when do you get a colonoscopy? And it just only matters how old you are. And I think
Yeah.
as we get like a better understanding of what the risk factors are, it could potentially get even more complicated, like, yeah, like the talent trial tackling like understanding what kind of cooking environment, you've been living in. And then, I'm sure I have patients even who ask about air pollution, and can you measure like the air pollution that I've been exposed to because I lived here and there. And I mean, that's such a great idea. But I don't know that we know how to do that right now.
I think,
Absolutely.
to your point, Jane, it would be amazing if we were able to remove some of these like bottlenecks, right? Because, if any one of us here wanted to go get a mammogram tomorrow, we just go and get a mammogram tomorrow, right?
Yep.
There's no shared decision-making visit. There's no special criteria one needs to meet. You just go and get it done. And yet that can't happen despite a woman who may feel for various reasons that she's at an incredibly high risk for lung cancer because she's got this family history or whatever, she doesn't meet the criteria, she doesn't have a way of getting it unless she's got the means to pay out of pocket, or she goes in and, complains of cough.
I think it's even hard
Yeah.
to get it even when you're willing to pay out of pocket. And in fact, I
Yeah.
know many people who will fly to other countries to get it
Yeah.
because they feel like that's the only way.
Yeah, absolutely.
And then
Absolutely.
there's
And
the
there shouldn't
fact
be
when
that
you
many
do present
barriers.
with symptoms, that your symptoms
Yeah.
aren't necessarily going to be completely, validated, right? Um, the cough especially is kind of one of the ones that's probably the most linked to a subsequent lung cancer diagnosis that was otherwise ignored
Yeah.
upstream, right?
Yeah. It's
Um,
funny that you mentioned about symptoms because it's a very similar thing we see in heart disease, right? We see in lung disease, and both of those
mhm,
circumstances for women, often symptoms are downplayed. And
mhm.
it always sticks out in my mind. It has since medical school. The first thing I learned about a woman having a heart attack is that women typically present with atypical symptoms. How can they be atypical symptoms if women are typically presenting with them? That means that's how women present. And we need to make sure that we're talking about diagnoses and
But
presentations
women
in
present
that
with
manner.
non-man symptoms. Yeah. Women don't present with testicular pain. Nope, they don't.
So we just need to be normalizing talking about these symptoms and making sure, Jane, to your point too, that we're getting that really robust history, right? I think hopefully in the not too distant future with Elaine Shum's beautiful study, hopefully we're going to be able to start incorporating some of these other really high risk pieces for our women patients or the first degree relatives, other exposures that seem to be really playing a big role in the development of cancer.
Right. I think one key thing as we look forward to all this amazing research that needs to be done and hopefully will be done is that we really encourage women to participate, because that's one of the
Yes.
huge problems with our understanding of risk factors, especially for women, is that so many trials involved, male participants.
Yeah,
So that I feel like that's an important message to get out there.
It can be a
absolutely.
little bit overwhelming because the gender issues span the entire continuum, right? From risk factors to early identification and screening, to treatment and outcomes and follow up. And it's just we're going to have to be very smart about targeting all of those areas in order to really try to impact the outcomes positively for our women who have lung cancer. There's no other way about it.
Absolutely. Leah, you mentioned something I really want to circle back to because I want to make sure that everybody has a really robust understanding of this EGFR mutations. And so you said, hey, we have to be especially thoughtful in our Asian populations and thinking about EGFR mutations. And at one of the recent conferences, they presented, thinking about cancers that are harboring EGFR mutations, about 10 to 15% of cancers in the United States harbor an EGFR mutation. If we start thinking about, especially our East Asian populations, we're getting over 50%. And we know that a lot of the never smoking women in particular are harboring mutations that are increasing their risk. We know that family history of EGFR mutation. We're now studying patients for germline EGFR mutations. How do we start thinking about this and incorporating this? Talk to me about opportunities for these patient populations that right now we're not really incorporating this on a routine basis.
Yeah, I think you hit the nail on the head. We're not incorporating on a routine basis. We got to make it routine, right?
Yeah.
So we've got to have reflexive testing for all pathologic specimens in order to even understand what someone's EGFR status is, right? And then from there, we can better characterize things and make sure that people get, the targeted therapies that they otherwise should be getting based upon their biomarker testing. So obviously it's a much bigger bucket of problems across the board, biomarker testing. But to your point, given the high potential for intervention, it's tremendous. It's magnified significantly. So if you've got an overall prevalence of EGFR mutations in a particular population, whether it's gender or ethnicity, etc., and you're not capturing it, that's huge. If you've got 50% of your patients that harbor a mutation that you're otherwise completely not, either you don't know about it or you know about it and you're not getting them access to the treatments that they deserve, then that's like a huge travesty. So reflexive testing, and making sure that everyone gets the testing done to help drive their care.
Absolutely. Absolutely. It'll be really interesting to see how that evolves, in particular for family members. Like I think about a very recent patient that I took care of, young, early 50s, bilateral early stage, caught accidentally. So yay, it was caught, right? Wouldn't have qualified for lung cancer screening, never smoker, both came back positive for EGFR, both fully resected. We're sort of in surveillance mode right now, but she has children. Right. So and she has a germline mutation. So how is this going to impact her kids? How should this be impacting their screening? There's so many really exciting questions that we should think about, opportunities for research that, gosh, hopefully in the not too distant future, we'll be able to answer.
Totally agree.
So one of the other things that we know is that women who have a history of breast cancer are actually at higher risk for a second primary in the future. And I don't know about you guys, but I feel like I operate on patients all the time these days who have had breast cancer, survived that. Now we all of a sudden have a lung nodule and everyone's scratching their heads. Is this metastatic breast? Is it new lung? And the vast majority of them are new lung. And Leah, one of the extraordinary things that you've done at your program, I've done this, it's been so much fun, is you have combined breast cancer screening with lung cancer screening, thinking about really looking at opportunities to put these together, be thoughtful of times. It is a population of people who are already highly interested in screening. Talk to me about how you built this program. What was your inspiration? How is it going? What are some of the lessons learned so that we can all be doing these things at our home programs?
Well, I mean, the anchor point is what you said a second ago, right? Which is that these are women who are highly motivated and plugged in and ready to get their cancer screenings done. Like you couldn't have a more primed audience to target, right? And the motivation actually came from when I was chair of the Lung Cancer in Women Task Group for the National Lung Cancer Roundtable, because we thought, well, wouldn't it be cool if we could be like breast cancer screening, be like breast cancer screening? Well, it'd be great if you could just do it all in one test. That would be the ideal thing, right? That doesn't exist for us. But at minimum, we could try to figure out a way to harness the opportunity and leverage it to educate patients and to try to automate some of the processes from a system standpoint to make it work. If institutionally you have a mammography rate of 80%, then you should have a lung cancer screening rate of 80%, right? Like at least among those who are mammogram eligible and lung cancer eligible, theoretically, you should have complete overlap. And so as part of that roundtable, we had a smaller task group and then partnered with folks at Vanderbilt, which you're familiar with, and then at Mount Auburn. And we had this three-pronged thing where we were basically just did this pilot study to quantify the overlap and to see how receptive women would be. Because you don't know, we make assumptions all the time as researchers, right? Of course, if we simply give them the opportunity, they will jump on it. Well, you got to prove that, because maybe they wouldn't jump on it. And we were right. They would jump on it. Like I want to say 85% or so of patients who were approached within the context of the study were excited about the opportunity for dual screening.
Yeah.
So, our screen rate went from, I want to say 35% to like 88%, something like that, for eligible women presenting for mammograms.
Oh my gosh, I love that. Big shout out to Kim Sandler, who's doing a ton of that research at Vanderbilt.
Yes, she was the catalyst. Absolutely.
She's amazing. She's amazing. And I think I love the idea of always leveraging people who are there, people who are showing up. And I think there's a lot of great opportunities, right? Like screening the women who come in, give them a lung cancer screening tool right there in that moment, see if they qualify. I have to confess, I am blessed with the most magical lung nodule coordinator. Her name is Patricia, and she pre-screens everybody coming in for mammogram
Mm-hmm.
And we actually do their scan the same day if we find somebody who qualifies, so
Mm-hmm.
that we're doing them same day. We have launched it at 2 of our 5 hospitals just to kind of test it out. And actually, we've got such positive feedback. All the other hospitals are like, when is our turn? Like, can we launch now? All the women are asking about it. They want all their mammos and CTs the same
Yeah,
day.
our
Amazing.
cancer center was over the moon excited about this. They were like, "What? This is amazing!" So they have agreed to fund the 2.0 version of it, to try to grow it and keep it moving. Part of our struggles with that is that mammography and CT scanning are not co-located. So from a system perspective, that kind of hurts us a little bit. But even with that albatross, we were still able to get some pretty decent results. So I think anybody can do it, provided that you do both of those screenings.
Absolutely. One
I
of the
think,
other things, oh, go ahead, Jean.
oh, I was just going to say that this sort of like touches on like an access issue, which is partly just like awareness. I think this would, doing stuff like that really magnifies the awareness with both the patients and their spouses and family members and everybody, their friends. Um, I guess, could you talk a little bit more about some of the other access issues that women who do qualify for lung cancer screening might be facing?
I mean, one of the access issues is kind of compounded by some of the other non-gender issues, right? Which would just be kind of some of the other social determinants of health and um, geography, rurality, insurance status, things like that. I think all of those things will disproportionately affect our female subpopulations. Childcare can be a bigger thing, probably more so for some of the other cancer screenings, less so for because of the age brackets, but not exclusively, right? I mean, a 50-year-old can absolutely, have a 5 or 10-year-old who needs childcare in order for her to be able to go and get her requisite screening. So trying to come up with novel ways to do things like that. I don't actually have personal experience with it, but I know that there are others, particularly in the mammography world, that have tried to tackle that.
I've
I think
definitely had patients say that they couldn't get their, surveillance on time or whatever study done on time because they were also taking care of grandchildren too. So,
Well, and I think that's something that's unique to our female lung cancer population is they tend to be younger.
yeah.
Right, they tend to be younger, they don't fit the mold. And so then if we're thinking, we don't have to build in childcare for lung cancer screening because they're all 65 and older, that's not true.
Yeah.
That's not true at all.
Well, and for better or for worse, guys, lung cancer is still stigmatizing across our whole population, but there's still sort of a lot of shame surrounding a lung cancer diagnosis. We have really done an excellent job at sort of normalizing being able to talk about things like breast cancer. I mean, you see celebrities talking about their journeys and sort of normalizing the experiences of going through chemo, of potentially losing your hair, of, they've got great t-shirts and catchy phrases, and they've given everybody a platform to be able to talk about it safely. And I think there's still opportunity for us to do that with lung cancer and to help normalize talking about it, and really especially socialize that just because you have lung cancer does not mean that you're a smoker, does not mean that you deserve it, does not mean that you are any less because of it. This is also a disease that can impact anybody, is killing more people than most of our other cancers combined, and we need to bring light to that and help anybody who has been touched by this disease.
I think that's where, in that advocacy space, I think where the sort of friends and family of lung cancer survivors have to kind of lead the charge, and they have been, because I still think that that stigma is very difficult to overcome as the individual patient.
Yeah.
Um, I find nothing more disheartening when I hear a patient who somehow feels um, anything less than worthy,
Yeah.
of the special care and attention that they're getting because of their history of smoking. I mean, it absolutely breaks my heart. Um, so we've got to do better, and they may not be able to do it for themselves at this juncture because we don't quite have, I think, enough momentum. But all the friends and families can absolutely do so.
Yeah. You guys, I started something fun new at my program. I kicked it off a little bit at Vanderbilt. I've been doing it, ever since I arrived at Crichton. And I called it Screen the Spouse, but it's like screen anybody else who's in the room. You would not believe how many husband and wife duos I've operated on because they often share similar risk factors, similar exposures. And it's not uncommon that, especially when one person is diagnosed with a cancer, that focus for healthcare really importantly turns to that person. And then sometimes the spouse forgets that they have screens that they're due for, or also share similar risk factors that would make them a candidate for screens. And so I try to ask, sisters, brothers, spouses, parents, if they're there, anybody else who's there, if they qualify for lung cancer screening, because it's another opportunity to grab another patient.
I think it's like especially powerful if, someone had a benefit from it, because I definitely have friends and family members of patients who have been lucky enough to have their screening in time, to have their curative operation, all want to be screened. So
I think it's also very all the more poignant given the fact that men with lung cancer do better when they're married.
They do.
Not the other way around, but the men do better when they're married. And so you kind of think, well, who's looking out for the wife, air quotes, for the female partner? Who's looking out for her? Because she doesn't get the same added benefit of having the spouse necessarily, who's totally plugged in and going to bolster her health in general. So I love that. Scan the spouse.
So it's a call to action, guys. We got to support all of our women who have lung cancer to make sure that we can make their outcomes just as good. Okay, you guys, I'm going to completely switch gears here. Let's talk a little bit about smoking, because I went down a rabbit hole recently, admittedly, because I started seeing some statistics, especially in my own state, that lung cancer is back on the rise again, which felt sort of like a gut punch after all of the education, this huge reduction that we've seen in smoking really throughout most of our lifetimes. And now we're seeing that rise again. And some of the really sort of poignant pieces of data surrounding it included much higher prevalence on television, on movies. We're now exceeding 50% of contemporarily made TV shows featuring smoking of some kind. Glamorization of it on social media. There's a new group of people called SIG influencers who are sort of glamorizing smoking. A lot of hashtags featuring, different times that you should be smoking. So, cigarettes in the club and cigarettes here and cigarettes there. And then we also have this new sort of vaping epidemic with people using, vape pens that we know contain some carcinogens, contain metals, things like that. How can we as a society help to sort of rein this in just a little bit? It scares me to think that we might actually start backtracking pretty dramatically in smoking incidences and having this known cause of cancer really start to rise again.
I actually did not know that. The SIG influencer sounds crazy to me. But I mean, like they've always said that when your doctor tells you, that smoking's not good for you and that you shouldn't smoke. And I do get a lot of patients asking me, not so much for cigarette smoking now, but more for like pot smoking and vaping and things like that. I mean, they do want to know. I think it does make a difference for doctors to be talking about it in general. And maybe we haven't been doing it as much and need to sort of like reinforce it again.
I agree with Jane in that I honestly was this many years old when I found out that smoking was back on the rise. And I'm not even joking. I was just in the car with my 20-year-old daughters just got home from college, and totally unrelatedly, like minutes ago, she was like, "Oh yeah, like kids are totally smoking now. Like it's the thing to do." And I was like, "Wait, what? Excuse me." I was so like, "What are you talking about?" Like, "Oh yeah, my girlfriends were at parties and they're like, oh, let's go outside. I just really, really want a cigarette. And so I just got back from Europe and it's like the chic thing to do. And that just, all the wrong reasons, right? But I was completely floored. So now I've had two sources telling me this information, and it's awfully disturbing. I do wonder, right, that I mean that's going to be another delay before we see that if the statistic bears out, before we see the full ramifications of that. And it'd be nice to be able to get on top of it earlier than we have historically, and try to leverage the current young people, because young people talk to young people. And I mean, I think to Jane's point, I think it's great when you go to the doctor and the doctor's like, you're not supposed to be smoking, but, a 20-year-old doesn't go to the doctor.
Yeah.
Right. So how do we get her? We need to try to support the no cig influencers.
Oh. Yeah.
Fight fire with fire. I don't know. I mean, I'm not a young enough person to know
But we should reach out to the SIG influencers because somebody influenced them to become a SIG influencer, I would imagine. So actually, now that we know about them, we should probably be reaching out to those people.
Yeah, because it's unquestionable. We've seen this kind of throughout history that it's your peers, it's your family, it's the marketing that really are some of the biggest drivers for taking up some of those habits. And so if we can hopefully, influence those, maybe we can have another big impact.
We can only hope.
Yeah. All right, you guys, this has been an amazing discussion. Really, really incredible. A lot of really sobering statistics when we think about our women. What are some of the take-home messages you want to leave all of our listeners with? What should we be talking about more? What should we be inspiring people to do to help take better care of our women facing lung cancer?
Well, no smoking, for sure. And yeah, to talk about it with your friends, families, and doctors, as part of all the other screening tools. I think that I feel like there has been more conversation about it in the last 5 years, even, but that we need to do more in terms of awareness, because it's nowhere close to our other cancer screening studies. And then just like how I was talking about all the research that we need on eligibility and stuff like that to get patients involved in research and wanting to participate in research. I think it's the only way to get the information that we need.
Absolutely.
Yeah, I agree. I think advocacy is key. All of the lobbying initiatives that are out there to help support lung cancer screening, for sure. I feel optimistic, honestly, because I think it's easy to be like, oh, poor lung cancer screening. We're just so underperforming compared to all the other cancer screenings out there, but they've been around for decades, like forever. And they never have gotten to 100%, by the way, but they're very good. So, like 70, 80% range, which is laudable. But I feel like lung cancer screening has the benefits of being the new kid on the block, in that we can learn from the others and we can leverage things. We have things like influencers, like we have more data. We have the ability to change the slope of the the lung cancer screening prevalence line faster than the others, because I think have more tools in our arsenal to do that with. So I'm hopeful. I think we're gonna get there.
Well, I think one other thing to address too is that, because it's always shocking to me that people would be like more willing to do what is technically like a more unpleasant study, like a mammogram or pap smear or colonoscopy, than getting a CT scan, is that there's so much fear out there about the radiation associated with the CT scan. And I think a lot of people don't know, first of all, that that's only like a theoretical risk, but like you have a real risk for lung cancer, and on top of that, everyone is being considerate about that anyway with these low dose CT scans that are just like 1/7 of the radiation of a regular CT scan. You know, you could get a scan every single year for 7 years, and that's like the equivalent radiation of one CT scan, which has never been proven to like hurt you anyway in the first place. So I feel like that's probably an important thing to get out there as well.
I love that. That's so, so critical. And as I think about sort of all the things you guys were mentioning, as we have these beautiful new studies come out, even just thinking about the FANS study that you mentioned, Jane, making sure that as these publications come out, grabbing that data and rapidly incorporating into clinical practice, that's a place where we've kind of consistently over time seen delays in incorporation of sort of newly approved therapies into standard of care. And so making sure that we're all being really nimble in our practices to make that a reality as quickly as possible is so critical.
Yeah, for sure.
Awesome. Awesome. Well, this has just been so much fun. To all of the women out there, happy Women's Health Month. I did want to take an opportunity to just share a very, very fun additional major women event from this weekend. Speaking of extraordinary women and celebrating women, I just wanted to give a quick shout out to Cherie DeVoe, another woman breaking down barriers, just like my two incredible colleagues here today. She was the first woman trainer to win the Kentucky Derby in 152 years. Completely amazing and inspiring. So to everyone out there, if you dream big, work hard, have passion, you can absolutely conquer the world. Wishing
wear a cool hat.
And wear a cool hat and cool shoes. Wishing all of our incredible listeners a wonderful rest of the day. Thank you so much for joining us. Please continue doing all the inspiring work that you do. Happy Women's Health Month. Guys, please keep educating everybody about lung cancer and the importance of screening to keep taking extraordinary care of patients. And as always, keep smiling.
Take care, everyone.
Thank you.
To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.